All right, moving on to part 3 of skin, hair, and nails. We're going to talk about lesions that can be precursors to cancer. Actinic keratosis. This is sun-induced damage to the epidermal cells. It causes a proliferation of abnormal pre-malignant cells. It's cumulative from birth. Dystrophic cells that may eventually transform into squamous cell carcinoma are what cause this actinic keratosis. It may occur post-irradiation to post-irradiation sites, people that get radiation treatments. It's most common in persons above the age of 50, and it has an increased incidence in redheads, blondes, and those with freckles. When we inspect, we're going to see erythematous, poorly circumscribed patches over or with overlying scales. And they can have an exophytic cutaneous horns on them. So when you feel them, they're going to feel rough. The treatment really is more preventative, such as sunscreens. We can use cryotherapy, electrodesiccation, and curettage when they are already in existence. Other things like liquid nitrogen, 5-FU cream or ointment, and even a shave excision. Our nevus sebaceous, you can see it in the picture there. It's a benign tumor caused by a malformation of skin with an abundance of sebaceous glands. Most of them occur in adults over the age of 40, but they're not really common, and there's no difference in prevalence between the two genders. When we look at those, we're going to see sharply circumscribed, solitary yellow, orange, oval to linear, kind of wart-like papules or nodules. They're usually over 5 millimeters. They can be pretty big, like you saw at the one in that picture. They're most commonly located on the head or the neck. They're actually frequently present at birth, and they grow and become more wart-like and yellow in puberty. Concerns that we might have about them is that they can turn into basal cell carcinoma. Trichoblastoma is the most common follicular tumor, and most are benign, and cancerous ones are pretty low grade when they are cancerous, and they rarely ever metastasize. The treatment basically is to cut them out. So we'll do excision of them when the person is a child, when they're first noticed. There is electrocautery or cryosurgery, but usually that can lead to a reoccurrence. Clark's melanocytic nevus here, dysplastic melanocytes. These are red to brown macular papular lesions. They don't have regular borders. You can see in the picture there that there's no discrete border. Most often occurs on the trunk and extremities, and it can appear mid-childhood. It develops abnormal characteristics in adolescence and on into adulthood. It has a genetic component to it. It is related to sunlight exposure, and it has a precursor to melanoma in persons that are at risk for developing primary malignant melanoma. So speaking of malignant melanoma, this can develop from benign melanocytic cells, so our nevi that we had talked about previously. The exact cause of why it goes on to develop into a malignant melanoma is not known, but UV radiation likely plays a role, and that's important for you to know. Advocate for all of that sunscreen that your patient should be using. It's spread through local extension and lymphatic drainage. It's most common in persons with fair skin, red hair, blue eyes, and freckles. It's tripled over the last 40 years. Its incidence has increased faster than any other type of cancer. It's second most prevalent cancer in men and the fourth in women, and the highest incidence is between individuals 30 to 49 years of age. It's highest reported in Australia. So the risk and the recognition, there is an acronym here called risk. So you're going to look at moles. More than 10 atypical moles increases the risk. More than 40 common moles person has red hair and freckling, like we had mentioned. People that have inability to tan, so skin phototypes 1 and 2, so these are your paler people. People that had severe sunburns, especially before the age of 14, but really any type of severe sunburn increases the risk. It's important for you to know that. And a family history, so that K stands for kindred. And you can see in the picture here how to spot it, asymmetry, looking at the border, the color of it, the diameter of it, and if it's been evolving or changing over time. Here's a picture here where you can see the normal moles on the top that, the idea is to kind of look at those and see how they could evolve into a melanoma, and they circle underneath them. So you can see the ones that are have become melanoma are really irregular in shape and size, and they in color even is not it's distributed very oddly. So it's not super easy to tell the difference, and that's why we really have to biopsy and have any moles taken a look at, especially ones that have changed over time. Staging of these, we have 1, 2, 3, 4, and 5, and you can see it's based on boundaries. So we have intraepidermal. Then once it breaches that dermal basement membrane, we've got tumors that go into the papillary dermis, invasion into the reticular dermis, and then invasion into the subcutaneous fat. The superficial spreading melanoma, you can see these pictures here. This is the most common form of melanoma. So the most common form of melanoma is superficial spreading melanoma, and that's important for you to know. It accounts for 70% of all cases of melanoma. It usually begins in the 5th decade of life, and it's more common in women. When we take a look, we're going to see this more horizontal. You can see in the picture there, this more horizontal type of distribution, and it grows over the course of 10 years. It's characterized when it's reaching 1 to 2 centimeters, and before it starts to have like a vertical growth phase that begins. You have these variation in colors. It has irregular borders. It may even have elevated margins. It can occur on any body surface, but it's most commonly seen on the legs and back, especially on women, and on the back in men. Nodular melanoma, you can see here, they have little nodules on there. It's about 15% of the cases, and we take a look at them, they're going to be round and irregular. They have that slightly elevated papule. It can be gray or blue in color with a dark background. It doesn't have that horizontal growth, but more of a vertical growth, and the lesions can ulcerate and bleed very easily. The most concern for this is that metastasis actually occurs super early. And so that ends up with a poor prognosis because it's not recognized before it's already started to spread. Lentigo malignant melanoma. This is pretty uncommon. It counts for 5% of all melanomas. When we see it, we're going to see it in sun-exposed area like the face and neck or extensor forearms. The lesions tend to be flat, and they kind of look like a stain. They're very dark, you can see there. They have flecks of irregular pigmentation in them. Acrolentiginous malignant melanoma is most commonly seen in our darker skinned patient population. It's most commonly seen on the tips of the fingers or toes. It develops like a blue and depigmented kind of area you see on the bottom left picture there. And it can present as a black nail or even nail loss in our patients. Basal cell carcinoma, on the other hand, in our lighter skinned patients, it's caused by cumulative sun damage over many years. It rarely metastasizes. It's very rare to see it in our darker skinned patient populations. It accounts for 75% of all skin cancers. And its highest incidence, again, is in these fairly skinned patients with red, blonde hair, and patients over the age of 40. There are different forms of basal cell carcinoma. One of them is this nodule ulcerative tumor. It begins small, it's pearly or translucent and waxy. You can see it in the picture there. It enlarges peripherally and develops a central depression. It often becomes ulcerated and scaly. The border's translucent, and the lesions are rarely pigmented. The superficial basal cell carcinoma, this has kind of an erythematous look to it. It's scalier. It's kind of got like a scaly, you could feel it and it'll feel rough. And there's usually multiple lesions present together. And then the sclerosing, fibrotic version of this basal cell carcinoma, the lesions begin as slow enlarging pore, and when they're fully developed, they appear as a slightly indurated yellowish white plaque, and it has, like most of these, have an indistinct border. It does blanch with pressure or with stretching. Our squamous cell carcinomas, you can see them in the picture here. It's the second most common skin cancer in our Caucasian patients. It's the most common skin cancer in Black patients. The incidence increases after the age of 55, and like most of these, sun exposure increases the risk. It's 35 times more prevalent in patients that are immunocompromised, and smokers have an increased incidence with lip involvement, like in that picture down on the bottom right. Bowen's disease is squamous cell carcinoma in situ, which means it's just confined to the epidermal layer of the skin. The UVB radiation contributes highly to the squamous cell carcinoma. It damages the DNA and alters its ability to repair. The keratinocytes undergo clonal expansion and form an actinic keratosis, like we've talked about. The uncontrolled proliferation of these abnormal cells leads to the squamous cell carcinoma in situ, and then the invasive, where it goes below the epidermal layer. The risk factors are the exposure to sunlight, and of course those sunburns, those extreme sunburns that the kids get, increases their risk of developing this over time. Our lighter skinned patients, people living in the South, having outdoor occupations which expose them to a significant amount of sunlight. Arsenic, which is actually in some medications and even in drinking water, can increase the risk. And HPV type 6 and 11 in tumors of the genitalia and type 16 in the periungual tumors, they can increase the incidence as well. Classically, they're described as firm skin-colored or reddish hyperkeratotic plaque or nodule, and you can look at it there in the picture. Frequently, there's a central ulceration. The scaling and crusting may be present. Lesions on the lower lip, they're firm whitish macules with a possible central ulceration. Often they're found in the sun-exposed areas, as you would expect, and 70% of the lesions occur on the head or the neck. They're more likely than basal cell carcinoma to metastasize. And the treatments are ionizing radiation. Moving on to clinical variations that we'll see in hair. We've got hirsutism. This is excess body hair in women with a male pattern to it. It indicates an endocrine abnormality, or it could be the consequence of medication. And then we have dandruff, which is the loose white flakes that we'll see from the scalp. Alopecia areata, this is well-defined, small patches, singular patches of asymptomatic, non-scarring, complete loss of hair. It's thought to be an autoimmune attack on the follicle that results in this abrupt loss of the hair. Patches can occur suddenly, even frequently, overnight, and the skin surface is a normal where the skin is or the hair is lost. It's relatively common, occurring in 1 to 200 people in the U.S. It has an equal distribution between the genders. There is some genetic component to it. Most of the cases are between the ages of 5 and 40. If it occurs before the age of 10, it's probably going to be a permanent loss of the hair. You've got the picture there on the bottom left. So it's small, limited lesions. 80% of the patients actually regrow their hair. Only 5% of the patients have this alopecia totalis, which is what's on the bottom right there, the complete total loss of all hair. But 1% of the patients will actually spontaneously regrow their hair. The hair pull test, if it's positive, meaning that the hair easily comes out, it suggests continuing activity, not that these people are really going to want you to pull out their hair. And then we have androgenic alopecia. This is male or female pattern baldness, and you can see the differences down there, grade 1, 2, and 3. It's genetically influenced. It's a progressive balding that occurs generally over time, unlike what we were just talking about. The patterns vary from bitemporal to frontal and or vertex. In women, if it's accompanied by development of male characteristics, an adrenal tumor needs to be ruled out. Telogen effluvium, this is the flooding of resting hairs, where you just have sudden alopecia like hair loss. It can be caused by an acute or chronic illness, even emotional or physical stress. There are tons of medications that can actually cause this. Some of them are listed here. Initiating event occurs from 2 to 6 months before you actually notice the hair loss, and it's common for the loss to continue for up to 2 to 5 months. Moving on to the nails, we're going to talk about infection-related issues, injuries causing abnormalities with our nails, and then disease processes that we can identify through looking at our patient's nails. Paronychia, this is super common, especially with people that are picking their nails, biting their nails. It's an inflammation of the paronychium tissue that's at the side of the nail there. Tinea unguium, this is a fungal infection. So many patients have this. It's relatively benign. It's not going on to cause other problems. In your older patient population, you'll see this so often, especially with their toenails. Topicals don't really reach the infection. You need to use systemic medications, but they are hard on the liver, and that's why you're just going to see this a lot in the patients, in our patient population, because they generally are just go untreated. So here we have the separation of the nail from the nail bed. This often occurs related to trauma, but it can be from psoriasis, or fungal infections or Pseudomonas infections even. Ingrown toenails, you often see these with people getting their pedicures or wearing shoes that are too tight, very much like the paronychia. The subungual hematoma, we've probably all anyway, bumped our toe or slammed a finger in a door and ended up with one of these, and quite often the patient will end up losing the nail. Brittle nails, this is a splitting or peeling of the distal portion of the nail. It can happen a lot from manicures and certain types of polishes or other things put on the nail. It can also have a genetic predisposition. Can be caused by prolonged immersion in the water or dry skin, or even be associated with a calcium deficiency. This habit tick deformity, this is caused by continual biting or picking of the nails, proximal nail fold by another finger. So you have that like scratching across the surface. This pincher nails, this is compression of both sides of the toenail. It can result from tight-fitting shoes, but the exact cause is not known. But I'll tell you, I see this a lot in patients. It's a pretty common occurrence. In anonychia, this is the absence of any nails at all, and you can see that in that little baby foot there. In koilonychia, this is the spoon-shaped nails. Talked about this way back in the day with in patho with iron deficiency anemia. You'll see this type of nail. Bose lines, these are transverse grooves. They're parallel to the lanula. They're often associated with significant infections, renal, cardiac, or hepatic diseases, or use of anti-cancer agents. The abnormality causes the nail to grow slowly or even to completely stop growing in short intervals. So the point that happens, where that stops occurring, this is the point where we see that transverse groove. Mies bands, you can see here in the picture, are white transverse lines going across the fingernail. It results from an acute systemic disease or poisoning. Historically, it's been associated with arsenic poisoning. Measuring them can help determine the duration that the problem's been going on for, and it's also referred to Reynolds or Aldrich lines. Lindsay's nails, on the other hand, are called half and half nails. Their proximal portion of the nail bed is whitish, where the distal end is red or pink, and this is associated with renal issues, chronic renal issues, azotemia, and hypoalbuminemia. Terry's nails, on the other hand, you've got this complete kind of white out there with just the very small distal portion of the nail being pink. This is most commonly associated with cirrhosis, and that's important for you to know. Up to 80% of all patients with cirrhosis, but also related to hypoalbuminemia, heart failure, and type 1 diabetes. And we're going to move on now to part 4.